Hey everybody, welcome back to my YouTube channel. Now I'm going to show you a couple cool things regarding this patient's case. Here she is in the initial. You can see she has a lot of overlap of her front teeth onto her lower teeth. We call this an overjet, and an overbite is when the top teeth overlap the bottom teeth. An overjet is this distance here you can see. We're going to go ahead and adjust this patient's outcome in Invisalign simulator. You can see that she has a nice outcome, but I'm going to go ahead and just improve this a little bit. She has some spacing that's still present in between the teeth in the very end. So we're going to do what we call, just so you know, this would have caused a lot of food impaction here. Patient would have had a lot of food every time she bites in if this stayed like this. But we're going to go ahead and just add a little bit of what we call IPR. It's a little bit of polishing pretty much in between the teeth, and it gives us the ability to close the space there. If we polish a little bit here and a little bit there on each end of the tooth, we can go ahead and close that gap. So now her gum tissue will grow in here nicely, and she'll be able to eat, without getting food stuck. Her gum tissue will be much healthier. She can avoid things like gingivitis, periodontal disease, and just buildup in general. That a lot of times is caused by what we call black triangles, like these little spaces here. So Invisalign is really helpful if the prescriber goes ahead and chooses to do a little bit of reduction here, a little polishing in between the teeth. We call it IPR, and that'll help close up her spaces nicely. Other than that, I think this is a really nice result. Coming from here to here is a huge difference. You can look at the patient's bite, and we can see in the very beginning, there's a lot of marks, green marks on the anterior front teeth here. This is the original. And that's not really supposed to be at all. A lot of the bite forces are supposed to be bilateral and simultaneous on both sides. You can see that once we align the lower teeth and we push them down and put them back into the arch, we have a nice U-shape, horseshoe-shape arch form here. There's no contacts on the front teeth anymore, and that'll help prevent a lot of the wear that you see that she had here on the front teeth initially. So this will be very helpful for her. This can lead to sensitivity. It can lead to total, attrition or wear of the enamel, exposing the underlayer, the dentin. It's just really not ideal. In addition to leading to TMJ problems, and a hypertrophic or enlarged masseter and temporalis, a lot of headaches it can lead to. So we try to really push the occlusal forces onto the back teeth, having them bilateral, on both sides and simultaneous when you bite down. Having them on the front is going to put the TMJ in a very difficult position, leading to inflammation. And obviously we don't want that. The only thing I would say is probably we can have a little bit less contact here on the canine teeth. So I'm just going to tip that in a little bit there, tip this one in a little bit there, and there you go. Actually, let's rotate this tooth as well, make it a little bit nicer for our patient. And we can bring this one up. Look how she's worn her canine teeth. This is not supposed to be flat. This is your vampire tooth, really. So it's supposed to have a point on the end, but you can tell that because she has these contacts here on the front teeth, this is her initial bite. The green dots show where she's biting. So look at how these canines have contacts there. And look where the wear is, right around there. When she's moving that lower jaw around, little by little, it's shaving the tooth. So, this is going to put her in a much more ideal position, and not only help with her TMJ, but just help with the longevity of her teeth. Let's add a little IPR here, close up that space. And now I like to just go back and check the aesthetics, from the beginning. You can see this is where she is now. This is where she'll be from the side view. Very nice, very demure. From this view, the only thing that I wish is that there wasn't so much of a space here. I would like to bring these upper teeth in a little bit to close that distance. I mean, patient's pretty much under the impression that she doesn't have to move the upper teeth because we agreed that her aesthetics are nice, but patients also have to understand that there is a big functional relationship, more important than aesthetics, but also they go hand in hand. So, a lot of them understand that after I explain it to them. And the midline, not a huge deal. I'm not so concerned about that. I mean, if she wanted to, we can add more IPR on this side and move it over. You know, if we want to be perfect, why not? Most of the times, patients and people in general don't understand midline drift. I mean, we all know the famous example of Tom Cruise, having a very off-centered midline. I mean, this does look nicer, so of course, anytime I see something that can improve the aesthetics, I'm always all for it. It's just, nice to catch these things in the beginning, especially before we start treatment, because it leads to a more predictable outcome. Who wants to go through multiple rounds of refinements and, when we could just catch these things in the beginning? I encourage all dentists to pretty much utilize this feature, get involved. Don't let Invisalign just send you back something and just to prove it. Why not get involved in the care and, organize what your patient is going to want, right? You're there chairside, what our patients want. We know how picky they can be, and that's all justified. I would want a perfect result if I was doing something, why not get the best that we can get? So, and why not just get it right from the first time? You know what I mean? So, this is telling me that we've moved this tooth a little more than they want us to. Move these teeth in a little bit more. And I kind of like now how we reduced that overjet, the space between the top and bottom teeth. Not a huge deal, but patients are going to wind up pushing their tongue in there. I mean, if you put a piece of paper, they wouldn't, and it was like it was before, they would, and this spacing was here, they're going to have it slide right through. I mean, it's not a huge deal. They can eat pizza, no problem, and like be able to bite down onto it. But why put them in that situation where they're going to be forcing their tongue into this space? You know, by the way, the tongue should really be here, right? It should be here. That's where it should rest, not onto the teeth. And the teeth, when you're not eating or drinking, should not be pressed together. They should be slightly separated. Our patient should be keeping the tongue right around here on the gum tissue area, and these back teeth should not be biting down. That, of course, will lead to a lot of occlusal trauma. It'll lead to a lot of issues down the line. Patients aren't always aware that they're doing it when they're clenching during the day, and they just have to get themselves in the habit of, basically adjusting their tongue posture and putting the tongue in a more desirable place so that you're not putting so much pressure on the TMJ and on the teeth. So this looks much, much better than what Invisalign just, basically put in through the algorithm. So I'm really happy with this result. I'm going to go ahead and approve this case, and I look forward to updating you along the way. So only thing I would say is this left side is lower than this right side. Now I'm going to get really into it and get even more picky. You can see that this grid view gives us a little bit more detail. Each box is in millimeter. This is one. If we draw the line across this side, you can see that this one is about almost a whole millimeter longer than this canine. So we have to bring this canine up now and make it symmetrical for our patient. Same thing with this premolar. Look, premolar is about 1 millimeter in length. We draw the line across. Up, it's almost two. So let's bring that one up. Again, these are things that, we notice after we complete treatment, and then if we don't catch it in the beginning, we wind up doing a refinement, or if, for instance, if the tooth doesn't move as expected, we do a refinement. But, why not put this in the best possible situation that we can from the start? Always a fan of doing it basically in one shot, and our patients will appreciate it as well. There we go. A little bit longer here on the midline by a hair. Listen, what is my patient probably going to do? Probably we're going to smooth this down. It's not much of an adjustment. It's about 2/10. I would say it's about a third to, it depends. I'm gonna talk to her. I'm gonna see what what she would prefer, but her options would be smoothing or bonding. So we'll see what she wants to do in the end. Let's go ahead and get this lateral to be in about that same position, or we can leave it long and shave it down, right? We can leave this longer than this one and smooth this down, or we can push this one up all the way, right? Not maybe not that much. We could push this one up to about where this one is, and then we can bond this, right? If our patient wanted to be a little bit more conservative, who doesn't want to be conservative? Why not preserve enamel? So I'm gonna call her. I'm gonna see what she would like to do. I'm gonna show her this over the phone. Again, we're very lucky in dentistry that we can do this planning, and a lot of medicine is going in this direction. Why not give our patients the best that we can get? It's nice to be able to predict things, and it makes for better patient outcomes, and it gives our patients more confidence in knowing that they're getting something that they've been involved in, possibly. They're not just getting a result, but it's a result that they're happy with, a result that they feel like not only have they seen an aesthetic change, but it's something that they want. Aesthetics is very personal, like each patient wants something different. Some patients don't even really care, or don't have an eye for aesthetics. So they're kind of just trusting your judgment. But my favorite thing to do, honestly, is I like to educate my patients so that we're on the same page. I don't just say, "What do you think?" And then they say, "Oh, it looks good." I explain things to them. That's my personal style. I like to get all of the questions out of the way in the beginning so that there is no question in the end about the final result. Like it was discussed, and patients feel happy about that most of the times because, I'm bringing up, I'm predicting what can happen during treatment, and I'm talking about it with them. So it's not like I'm explaining myself now. You know, I'm just now I kind of told them in the beginning what the possibilities are, what can happen during this treatment. I've properly, educated my patient about that. And now, if it winds up being better, great, than I predicted. If that situation arises, then at least we discussed in the beginning and people are happier that way. But anyway, this came out really nice. I'm glad we were able to, put this all together. Let me just take off this and this. And now, we can see this is the beginning and this is the final result. Look how aesthetic that is. Look how look how this is even on both sides. I mean, yeah, like the gum line is a little higher in certain areas and whatever, but we have to remember that, this patient had a little bit of recession in the beginning, like not everything is 100% here. There's a little wear on the teeth, but these are things that we can touch up later with either bonding or polishing the edges of the teeth to make them straighter. And of course, we always throw in a nice whitening in the very end of treatment just to give our patients a little bit more pop, a little bit more motivation to, keep their smile vibrant and be happy with the result. Feeling confident is of course important. And I'm looking forward to helping this patient. Oh, here we go. We got to correct this as well. I'm going to tip this lingual a little bit. Maybe rotate this a little bit. Lingual. Rotate. Lingualize here. Oh, a little too much. Why? We have to add probably a little IPR there. Not enough room, probably. Too much movement in the canine. Let's make some space this way. Actually, I'm probably affecting the midline, which we corrected before. So, that's why it goes to show like this cannot always be 100% the midline. There's certain limitations in root movements and different, features of Invisalign. I mean, if the patient got braces, yeah, like that might be 100% predictable. It might be what she really, if that's what she really wants, and this is a conversation, we need to have as doctors with our patients. If she really wants a perfect midline and that's her thing, then I would say either get veneers or go and move forward with braces. You know, if for some reason there's a limitation in the Invisalign treatment that cannot accommodate what this patient wants, and why not discuss that right in the beginning? Why would you want to be in the middle of this treatment and then you find out patient is still not happy in the end, which could happen because of a midline error, or not an error, but a limitation in the improvement here in the midline. So anyway, I'm really happy with this. I'm going to translate this a little bit, maybe one drop less. The occlusion, a little heavy there. All right, so if we can't move that one as much as we wanted to, let's go back to our grid. This one needs a little help. That looks good. Okay. Again, if patient wants this straight and everything, bonding is an option, or smoothing the edges of the teeth. Let's go ahead and move this one out a little bit, out of the way there, so we have a better occlusion, better occlusal pattern. Let's see if we can go ahead and resolve this error. It's an error, but it's because Invisalign is saying, hey, we can't do all those movements. That is a limitation. So it's built to say, you know what, you're moving this root a little too much. Let's keep it back to the 1.5 millimeter range. Let's go back to our occlusal pattern. Let's take off the grid. Let's see what we look like from the beginning. Okay, let's put the grid back on. See if we're symmetrical with everything. Okay, I'm going to put this right here. See where we're at with our laterals. Oh, this one's a little too high still. There you go. Mm, canines. On point here. Yep. Turn the grid off. I'm very happy with this. Let's go ahead and approve this case. Again, we came a long way here. Our bite is where we want it to be. Do we have enough attachments? And remember with the attachments, if you ask a patient their opinion, they're going to say, no, I don't want attachments. But, you know, it's really not that easy to move laterals. Look how small this tooth is. When you place this Invisalign onto this tooth, it's not going to grab it as well as it will this front tooth. That's why we don't need an attachment on this front tooth. This lateral needs a little bit more pull and force really from the Invisalign tray. So that's why we add this so that we can move it more predictably. But all right, everybody, I hope you enjoyed, and I look forward to showing you the results of this case. Stay tuned, and we'll talk soon. Have a great day.